Welcome to episode number 1 of Carry On, a new live stream that is focused on, well, pretty much whatever I'm interested in. So I like neuroscience, psychiatry, philosophy, stuff like that. And so today we have Ellie Cole. Um, Dr. Cole, she has done some incredible stuff. She's currently a postdoc at the Brain Stimulation Lab at Stanford and director of the RTMS lab at the Wuxi Neuroscience Institute. She did her PhD in cognitive neuroscience at neuroimaging at the University of York in the UK and learned about a lot about neuroscience there. And she is working on some of, in my opinion, the most exciting research in psychiatry, maybe in my lifetime. I think that it's not an understatement to say that TMS has the potential to revolutionize how psychiatry is practiced. And so, in any case, she's one of the she's the lead author on a big paper that just came out, and so she's going to go over. She's going to tell us a little bit about the paper. But first off, thank you, Ellie, for joining us on the program tonight.
Yeah, it's a pleasure. Thank you for having me.
Yeah. So, so first off, I guess I want to ask a few questions, just kind of about you and your interest in neuroscience, and then we'll get to the meat of what you're talking about. But how did you wind up in TMS of all places?
That's a very good question. Yeah, and not something people ask me that often either, and I'm always surprised by that. And I'll talk more about what TMS actually means for people who are wondering what that means later on. But I initially in my PhD was exposed to TMS more as a probe of brain function. And then I was lucky enough to do a project with Professor Peter Endicott in Melbourne as part of my PhD. And he was actually working on TMS treatments for autism over there. And I really started learning more about its potential, particularly interested in its applications in psychiatry, and then came over to Stanford to develop the treatments more there.
Yeah, no, that's actually pretty similar to my story too. So for those who have not, who are tuned in and don't know TMS, it's transcranial magnetic stimulation, and it's a little magnet. You can, well, it's actually decently sized, about this big. Put it on your head, and it stimulates. You're able to zap about a centimeter of cortex, and you're able to activate it. Or cause it to fire. And so the question, and what we can figure out with it, is that this is the big question. Like, what can we do with that? And so Ellie's going to tell us, what can you do with the TMS coil?
Yeah, so many things, like I said, probing TMS function, but also treatments, which is what I'll talk to you about today, about developing novel TMS treatments. So TMS is right now FDA approved for depression, OCD, and migraine, but there's lots of evidence out there that it's effective for other conditions too. But today I'm mostly going to be focused on treatment-resistant depression.
Cool. Well, good. Well, for those who are watching, feel free to ask questions in the live chat. As a reminder for those who haven't tuned into a live stream of mine before, the rules are be nice, or we're gonna block you. So just have respect, and yeah, that's pretty much it. If you ask questions, we'll collect those questions, and we'll have some time for Q&A at the end of the hour. And yeah, pretty much we'll go from there. So without further ado, why don't we get going on the actual presentation part?
Okay, great. Let me share this then. Fingers crossed this is going to work. We did test this before, so it should be working. Okay, can you see that?
I can.
Okay, fantastic. Okay, so this is a bit of a mouthful. So Stanford Accelerated Intelligent Neuromodulation Therapy. So we call it SAINT for short. So this is the treatment I'm going to mostly be talking to you about today, which is something we've been developing at Stanford, which is a novel accelerated form of this TMS treatment for treatment-resistant depression.
And first, can I tell you, I am just very impressed with your ability to come up with an acronym. That is, for those that don't know, coming up with a good acronym for a treatment is one of the most. It's an art form, and this is like the Mona Lisa of acronyms. So I'm first off, congratulations on the name. We love it.
Thank you. I cannot take credit for it. The PI, Dr. Nolan Williams, came up with this after a few meetings. We did give it the final okay at the end, but yeah, I cannot take credit for it. And yes, I think you always have to have a good acronym, definitely. Can you see all the text? I can't see how much you can see, but yeah. Okay. So first of all, I'm just going to give you an overview of what TMS is, so transcranial magnetic stimulation, and the FDA approved protocol for depression currently, and then talk about how we might be able to optimize this treatment further to make it more effective, and tell you what our SAINT protocol involves, and share with you the results from our open label trial that were just published in the American Journal of Psychiatry, which we're really excited about, and then just give you a couple of case studies at the end as well, just to illustrate the kind of individuals that were in this study. So first of all, this is TMS. So TMS is a non-invasive brain stimulation technique that can be used to either increase or decrease activity in brain areas. So for example, if a brain area or brain network shows increased activation in a particular psychiatric condition or neurological disorder, then we can use TMS to try and dampen down this activity. And similarly, the other way around. So when the machine is turned on, an electric current runs around that coil. And when you have an electric current in this direction, it creates a magnetic field this way. So the magnetic field can travel through the scalp and the skull and activate the brain region under the coil. So this is what TMS actually looks like in real life rather than in a diagram. So on the left here, we actually have my PI, Dr. Nolan Williams, from the Brain Stimulation Lab at Stanford, placing a TMS coil on a participant's head. So you can see the TMS coil just rests on the head there. So people are fully awake when they're having this treatment. They're sitting in what looks a bit like a dentist chair with the coil placed on the head. On the right, this is a different type of TMS machine, but it's a similar idea, this dentist-looking chair with the coil on the head. So there's different types of TMS that we can apply. The first type is single pulse. This is where we deliver just single pulses of TMS, and this is used to measure the amount of activity in that brain region. So the most common reason we do this is something called a motor threshold, which is what we use to decide what intensity of stimulation an individual needs for TMS treatment, because everyone's brain's different and needs a different amount of stimulation to activate it. So the way we measure that is by delivering single pulses to the area that controls your hand, and we increase the stimulation intensity little by little until we see this little hand movement. And your motor threshold is the amount of stimulation you need, or the intensity of stimulation you need to make the hand move at least 50% of the time. And we use that to use the intensity for your treatment, because unlike other brain regions, the hand region has this great output. So we can see exactly how much stimulation we need to get it to activate, because we see this hand movement, whereas other brain areas don't have this nice output. And the other form,
have you ever gotten single pulse?
Yeah, I've had all of it. I always think you should try everything so you can exactly say how it feels, because patients know if you're not fully explaining how it feels, they know you haven't had it yourself.
Yeah, I think the same thing. I always put myself through whatever protocol I was going to put my participants through. But yeah, it's pretty weird. It feels like if you get you hit this part of the brain and then you get like a thumb twitch or whatever it is, and it's like, did I do that? No, I didn't do that. But hey, there it goes.
You feel like a puppet.
Yeah.
Very strange, especially when you don't. Sometimes people can do it so well that you can't even feel it. So if you're looking straight ahead, you don't believe them, and then you look down and you see your hand moving. That's a very strange feeling. Yeah. I haven't had speech arrest done to me though. That's what I haven't had done.
Oh no, that's the best. That's the best.
Yeah, I'm a bit scared of having that. But for those of you who don't know, that's where you stimulate the area of the brain involved in speech to temporarily stop it. There's lots of good demos online if you want to see that.
Yeah, I've got, I don't know if I can do this with, I'll see if I can pull my own speech arrest up. I'm not sure if I can do that. I haven't done this live, but I'll see if I can pull out. Go on, and I'll show a speech
Keep
arrest.
going, maybe a treat at the end. So another form of TMS is repetitive TMS, which is what we typically use for treatment. So this is where we deliver multiple TMS pulses in a particular pattern to a brain area. So traditionally, this was split into either low frequency TMS or high frequency. Low frequency typically being about 1 pulse per second, and high frequency typically being about 10 or 20 hertz. So low frequency TMS is aimed to reduce activation in the brain area that you're targeting. So if a particular condition had hyperactivity in a certain area, you might apply low frequency stimulation to try and dampen that down to normalize the activity. Whereas high frequency stimulation increases the activation in that area. And more recently, a type of TMS known as theta burst stimulation has been developed, which is more effective. So instead of having these single pulses that are delivered at equally spaced intervals, you have these quick bursts of stimulation. So instead of single pulses, you have 3 pulses very close together, and that's repeated. You can either deliver theta burst stimulation continuously, usually only for about 40 seconds, and this reduces activity in the area you're targeting, or you can deliver it in these 2-second bursts with 8-second gap, which is called intermittent theta burst stimulation, and this increases the activity in the brain area. So this has been shown to be more effective. So ITBS, just 3 minutes of that stimulation has shown to produce the same effects as nearly 40 minutes of the traditional high frequency TMS. So this is great for patients because they only have to have 3 minutes of stimulation instead of nearly 40. And it also means we can treat more people in a day in one clinic. So like I said, TMS protocols have been FDA approved for depression, OCD, and migraine. So these TMS protocols target different areas of the brain depending on the brain areas that are affected in these conditions. But I'll focus on depression today. So I'll talk you through what that protocol looks like. So the TMS protocol for depression targets an area of the brain called the left dorsolateral prefrontal cortex, which is a mouthful and basically a fancy way of saying the front left of the brain. So you just have to remember it's in the front left side. And this involves
it's like here. It's
yeah.
like about there. And,
yeah. And involves daily stimulation for about 6 weeks. So this is Monday to Friday, and that results in 30 sessions. And this can either be, like I said, the 40 minutes of the high frequency TMS or the 3-minute theta burst stimulation sessions. These are shown to be equivalent. And the stimulation is delivered at 120% motor threshold. So 120% of the intensity it takes to move your hand. So greater than that. So this is an effective FDA-approved treatment for treatment-resistant depression, which means that people have already tried antidepressant medications, but there are limitations to the current FDA-approved version of TMS. So right now, approximately 50% of individuals who receive this treatment are a responder, which means that their depressive symptoms are reduced by 50% or more after this 6-week treatment. And about 30% achieve remission, which means they no longer meet clinical criteria for depression. So these response and remission rates are encouraging because these individuals are treatment resistant, but I'm sure everyone can agree there's still room to improve them. We always strive obviously for 100. And the 6-week duration itself is also a downside. This really limits the use in emergency settings or inpatient settings where we really need faster treatments. And responses aren't typically seen until about 4 weeks into treatment. Obviously, everyone's different, but this is a long time to wait to see a response. And the FDA-approved treatment, TMS treatment, uses scalp measurements to find the this brain region roughly. And although this is very cheap and easy to do, which is a bonus, it can sometimes miss this brain region entirely because everyone's anatomy is different. So there's a number of ways we can try and improve these protocols. And we designed SAINT, I'm not going to go through the full name again. It was designed to optimize this treatment. So an attempt to make this treatment both faster and also hopefully more effective as well.
Yeah, and just to emphasize that point, I think when people get to the point of treatment-resistant depression, the the degree of symptoms and the options that patients have at that point. So this means they've tried Prozac didn't work. They tried Zoloft, and Zoloft didn't work. They went to therapy didn't work. They've been really trying to get their treatment for a long time, sometimes for a very long time. And so as of 10 years ago, we were doing backflips that we were able to get 30% of these people better. And so like that's TMS itself, the accomplishment of TMS itself for treatment resistant depression is itself very exciting. And I think that excitement still hasn't, I don't know, caught on or spread around. But as Ellie's saying, like that's 30% is good, but I mean, really, can we do better? So
yeah, we always strive for perfection.
So are you a perfectionist in things other than depression remission rates?
Yes. I don't think anyone at Stanford isn't a perfectionist. Okay, so the first thing that we did, see if I can get this to work too. This moved last time. Yeah. Okay. So the first thing that we did was individualize the area that we were stimulating for each individual. So before individuals received the SAINT treatment, they had an MRI scan, and this was used to pinpoint exactly the area of that left dorsolateral prefrontal cortex that we wanted to stimulate. Because previous research had shown that if by chance the scalp measurements worked out that the TMS coil was placed over an area of the left DLPFC, which is anti-correlated, which means if this brain region's on, this other one's off, and they're in sync like this. If it was anti-correlated with an area called the subgenual cingulate, which is involved in negative thoughts and rumination deeper in the brain, then you had a better TMS outcome. So we took that chance element out of it and specifically targeted the area of the left DLPFC that was most anti-correlated with that subgenual cingulate for that individual based on their brain connectivity, so that we had more precise targeting. And we also delivered 10-minute sessions instead of the usual 3 minutes of intermittent theta burst stimulation. So there'd been a blinded trial of ITBS that had delivered 10-minute sessions instead of those 3-minute sessions. And they'd found significant antidepressant responses after just 2 weeks, which is much faster than normal, suggesting that maybe these 10-minute sessions are more effective. We also delivered a lower stimulation intensity actually than the FDA approved version. And this is because intermittent theta burst stimulation has been shown to induce greater changes in brain activity when delivered at 90% compared to at 120% that's used in the FDA approved version, and also greater changes in functional connectivity as well when delivered at 90 compared to 120. And we also delivered multiple sessions a day. So this is what our schedule looked like. We were very busy. So we actually delivered 10 sessions in a day, which is a lot. And each session was delivered hourly. So there was a 50-minute gap in between. And this was done because sessions, research before has shown that sessions delivered between 50 and 90 minutes apart have a cumulative effect on each other. So they have a greater effect when delivered this apart than delivering the same number of sessions on different days. And we delivered this for 5 days. So each day of this protocol, that people actually received the same number of pulses as an FDA-approved TMS 6-week protocol in just 1 day. And then we delivered this for 5 days. So they actually received 5 times as much overall stimulation than the 6-week treatment course. And the reason that we gave so much TMS is that no one's actually done a dose response curve for TMS. So we have this standard treatment of 6 weeks, 30 sessions of TMS, but no one's actually done a dose response curve for TMS. So we don't actually know, unlike medication where we know exactly the doses that we should be giving people, we don't actually know how much TMS we should be giving. And this study actually gave people more stimulation than that. So people who had not responded to a 6-week treatment course, they gave them further treatment for up to 12 weeks and found that 61% of people that didn't respond initially did respond with further treatment. So maybe for quite a large proportion of people, we're just simply not giving them enough stimulation. So we gave them 5 times as much to see if maybe that was true. So just a quick overview of how SAINT is different from the FDA approved. We used personalized targeting, so stimulated this particular brain region based on their brain connectivity. We delivered a lower intensity, which is actually more comfortable too, which is a nice bonus. 10 sessions a day instead of 1, so long days. The sessions were delivered every hour, and each session was 10 minutes rather than 3. And this means that they got 5 times the amount of pulses that they would have gotten an FDA approved stimulation. Okay, so this was.
So this is also, these days are compared to normal TMS. This is a revolutionarily large amount of TMS, which is exciting, but also these days are long. I mean, like,
very long.
Who was
for everyone, us included.
How was that? How was it to be there for, like, how long were your days? Like, when did you start for setup and when did you finish? When there was
very long. For the first year I was doing it, I was also commuting.
Oh
from
gosh.
San Francisco, so I had very, very long days. I think I woke up at 5 and got home at 8. But I moved. So yeah, but it's at least, so people are there 10 hours a day, and then you have set up and close down. So it's, even if you're really efficient, it's at least 11 hours. Yeah, usually 12.
Those are long days back to back, and then you do that 5 days a week. But then what happens when you have another patient the next day?
So we do it Monday to Friday. Yeah.
So you take your weekend off and you just get back at it?
Yeah, we usually have scans and sometimes assessments at weekends, but yes, we then get back to it Monday to Friday. And that's if we're not running inpatient 7 days a week.
Oh man. So
yeah.
you're saying researchers work hard.
Yeah, researchers work hard. They make us work.
And patients too. The other thing to appreciate here is, man,
it's definitely harder for them.
Mm-hmm.
Definitely harder for them.
Yeah.
But they were all fantastic. I cannot say, I mean, honestly, people were like, how are you going to get people to do this, especially when they're feeling so awfully? And these people were just incredible. And we had very early MRI scans, usually at weekends, that were at 5, 6 in the morning, and they were always there. They were fantastic people. We really, really lucked out. Okay, so this was our open label trial in 21 individuals. So as you can see, the average duration of depression is nearly 23 years long. So these people have really been experiencing depression for a very long time. And the average adequate antidepressant trials are more than 5. So this isn't just the number of trials, this is adequate, managing to get up to the adequate dose and for the extended period of time that you have to be on that dose. So this doesn't include ones they couldn't tolerate or couldn't get up to the final dose. And 7 of the 21 individuals had also tried the FDA-approved TMS protocol and not had adequate antidepressant effects from that as well. So very treatment-resistant individuals, and these are all severe depression at the time they came in as well. And these were our results. So sorry, it's a very busy slide, but we had a 90% remission rate in this open label trial, which is unheard of in this level of treatment-resistant depression. And we can see on the left here what the curve looks like over the days of treatment. So on average, individuals were remitted on the 3rd day of treatment. And on the right, it shows out until a month after the course had finished. And the responses held out until a month. So although this is open label data, we were really pleasantly just surprised by these results. All the long days are definitely worth it. But this is the question we keep getting asked by everybody. Is it all placebo effect? And I can't reveal too much right now, but I can just say wait for our blinded results. Hopefully we can get those to you as soon as we can. But for any critics out there, I just want to put the 90% remission rate into context. I know you said something about this earlier, but treatment-resistant depression is it's very hard historically to treat this and move the dial. So these are the open label remission rates for individuals with treatment-resistant depression for these other interventions. Ketamine has got a lot of publicity recently. Deep brain stimulation is an invasive brain stimulation method. ECT, the current gold standard for treatment-resistant depression, and magnetic seizure therapy, and the FDA-approved ITVS, obviously. So as you can see, the 90% remission rate is substantially higher than all of these ones for these treatments that exist right now. So although this is open label results, we are really excited about it. I think that just puts it into perspective for everyone who isn't familiar with treating treatment-resistant depression. Yeah. And I just wanted to give you two cases as well to really give you further an idea of these examples. So one individual had tried invasive vagus nerve stimulation. So they had electrodes implanted into their neck, and that didn't work for depression. They tried ECT. They're actually on the waiting list for deep brain stimulation, which is this invasive brain surgery that I talked about. But that trial was actually cancelled due to not showing efficacy. So they didn't make it into there, but they did qualify for that. They tried ketamine. They tried more than 10 adequate antidepressant trials, psychotherapy, and their current episode of depression, so not just their depression length of illness, but their current episode was 27 years. So this individual really felt like they tried everything. And this individual completely remitted from depression after our 5-day treatment. And the second individual was actually in our inpatient study. They had had 4 previous suicide attempts, 3 previous psychiatric hospitalizations. They tried more than 13 adequate antidepressant trials, more than 34 years of depression, and tried ECT, which didn't work for them. And this individual remitted on the 4th day of treatment and was still fully remitted 6 months later at our final follow-up from that study. And I actually had further contact with them nearly 2 years later, and they were still remitted without any further treatment. So this was one of those amazing cases that really makes you keep going with these things. Yeah, so just to conclude from my slides, that TMS, although it is an effective FDA-approved treatment for treatment-resistant depression, there's still ways that we can further improve this to hopefully get more towards the 100% remission rate that we all strive for, all the perfectionists at Stanford. The brain stimulation at Stanford, including myself, developed SAINT with the aim of making treatment faster and more effective. So the SAINT protocol is just a 5-day long protocol. And if anyone's listening who's suffering with treatment-resistant depression, shameless plug, obviously, we unfortunately aren't running any of our clinical trials right now due to the strange times that we're living in, but we are really hoping that we can start our clinical trials up again towards the end of the year. Obviously, I can't promise anything because none of us can plan that far in advance, but there's a link, and feel free to share it with other people who are struggling right now. You can fill out our screening questionnaires there, and then we can contact you if it looks like it might help you whenever we are able to run these studies again. Yeah, and thank you for listening, and I look forward to the discussion.
Yeah, well, Ellie, thank you so much. This is just absolutely groundbreaking stuff, and I guess, you know, some of the questions that have come up for me around this is, you know, for a long time there was kind of the chemical theory of depression, the serotonin theory, that like the reason why people are depressed is because they just don't have enough serotonin, and so we need these medications to treat people, and so, you know, so for a long time, at least a popular story in depression was we need more serotonin. And so Prozac and Zoloft and all of these other medications worked on those systems. I guess after getting results like this, how does this make you think about what depression is?
I think the way we view depression, and it's different, I guess, in every lab, like you're saying, everyone has their theories, it's really on a neural network level. And we've done some fMRI data. I couldn't share it with you today because it's not published yet, but I will maybe at a later date, looking at the neural network changes. So I really think that this stimulation that we're providing to the left dorsolateral prefrontal cortex is really just a gateway into these changes that it has further down, particularly with the subgenual cingulate and its connectivity with the default mode network. And so it's really, and the salience network and things like that. I think it's a disruption of emotion processing and cognitive control. That's how we like to say it.
And so, yeah, I mean, I think this is the future of how psychiatry is, and it's sort of, when I think about it, it's kind of like it's kind of backfilling the story of why was it that Prozac worked in the first place, and Prozac or an SSRI works. It just works for in the first trial something like a third of the people that use it. Remission rates are about a third the first time and about a third the second time, and it kind of drops off after there. But why do you, or do you have any thoughts about why Prozac was, or these SSRI medications were effective if it is all circuits?
Yeah, and why does it work for some people and not others? I think there needs to be more communication between researchers doing these neural network levels and individuals doing all this extra research on serotonin and bringing them together, because TMS obviously affects these things too. So we just need to integrate a lot more, definitely, to line up all of these stories.
No, I think this is definitely something that's a time that, because we've got such a good probe now, we could do a lot of cool stuff that we didn't do before.
And maybe depression is many things. I mean, I think it's very naive of us to say, oh, we're going to try and aim for 100%, because I don't think one thing is gonna, I mean, I know we had 90, but that was in obviously 21 people. I think we're going to have to find ways of further breaking down subtypes of depression in order to better treat it further down the line, because I mean, there's just so many ways it can manifest, so many ways that individuals end up in the clinic. I think it's very unlikely that there's one answer for everyone.
This psychiatry in the late 20th century doing the best it could to come up with diagnoses, and then that's sort of including things that might have multiple biological causes. And so maybe if it's a circuit problem, then TMS really gets it every single time. But if it's a chemical problem or a hormone problem or a something else kind of a problem, maybe those are the reasons why it's not responding. But this also makes me think about what are some of the unexpected. Well, the results are unexpected. Like nobody expected to go into this say 90% remission rate. We're not just going to match the best. We're going to beat the best by like factor of 2. But in terms of unexpected, what are some other things you noticed throughout the treatment, or about what people said, or about people's experience that might not be as publishable, but was interesting to you?
Some really interesting things obviously came through that were more anecdotal. So lots of people explained to us that not only were they not depressed anymore, they had this heightened sense of mindfulness, really something that we were all very jealous of by the end. So it went even further than this antidepressant effect. They were suddenly much more mindful than they had been in their entire life, even in their times in which they hadn't been depressed, which is something we hadn't thought about. And we are now adding mindfulness questionnaires to all of our studies to think about that more. Other things that we found, one thing it really didn't seem to help with, although it helped with the main depression symptoms, was sleep. So I think individuals who have very disrupted sleep may need a different stimulation target, because even individuals who, and maybe this is a way of passing out who has separate insomnia and who, as well as depression, and maybe people who just have sleep disruption due to depression. But we found lots of people were saying, I feel fantastic, but I still can't sleep. which is something we didn't expect. We thought people would either, all the symptoms would get better or they wouldn't. It was separate things. Same with anxiety symptoms with depression. Even individuals who didn't think they had a separate anxiety diagnosis, they just thought they were MDD, their anxiety symptoms didn't tend to get much better. They were the ones that tended to stay behind, which again maybe is a way to say, well, perhaps maybe you do have an anxiety problem, or we're just taking some symptoms of depression and not others, and we need to have more than one target. All interesting questions for future research.
Yeah, no, I think this is all these things that are like what was attached to that thing that we just, turned up to 11. That's where mindfulness lives. I guess that's where it is.
Well, the thing that was, I don't want to say funny because it's not funny, but one thing we really didn't expect was how people weren't actually ready to have such a quick response. Because usually when you have a treatment, you have these weeks to adapt and you're slowly getting better. Whereas we had some people who were well on day 1 and on average, obviously well on day 3. And people were like, whoa, my life is completely revolved around the fact that I have depression. I'm not ready to, it's not that they didn't want to be well, obviously they did. But there's so many factors they need to then change in their life after that with being well. Lots of them were on disability, things like that. And they started to panic. And we said, please stop panicking, concentrate on enjoying this moment. You do not have to sort the rest of your life out right now. So we had lots of sit downs with people at the end of treatment saying, please just enjoy this moment and don't go off and try and run a marathon and get a new job and everything by Monday. Please just, it doesn't matter, enjoy it. So that's another conversation we really didn't think we had that with nearly everybody.
Yeah, no, and that is, you're absolutely right. Like our sort of fast working antidepressants had historically been like 8 weeks. Like try your antidepressant, and like if it works, you have a nice long 2-month period to adjust to your new brain, as opposed to like Monday morning you're in the pits of despair, and like Tuesday morning, world's amazing. The world's, the birds are singing and you see the flowers, and like literally in 24 hours for some people, and it's just astonishing.
It's amazing. Yeah, we had a few people because we would come in and start around 7 in the morning, so it'd be dark quite a lot of the year at that time. And I remember a few people would sit, Stanford car park, it's not good looking. And the 2 people in particular I can remember were sitting on a bench looking at the car park. I was like, why are you okay? Why are you here early? And they just said, I'm just enjoying this beauty around me. 6:45 a.m. and you're looking at a car park thinking it's beautiful.
And as a translation, in English, the real English, that's parking lot for
parking lot, yeah. Yeah, I forget. I have all these, yeah.
We speak real English around here, so
Still haven't caught up on all the sayings. No. Yeah, that was funny. Obviously I can't even imagine how wonderful it must be to have it all lifted, but especially have it lifted so quickly. They all found the beauty in such small things. It was lovely. But yeah, sitting in the car park 6:45 a.m. we had at least 2 people do that.
That's an odd behavior.
Yeah.
I've never done that. But yeah, the beauty thing is also very interesting, very notable. I had one patient tell me it was like going from like standard definition to like 4K or like HD. Like the world was it wasn't, he didn't use a color metaphor, but it was like high definition. But a lot of people say like the world was black and white, now it's in color, or there's like almost a visual experience of not being depressed.
And the skin change, you can see it in a person too. I can't explain it. We need to film them, but the skin looks different. There's like a dulling when they first come in, and then they're suddenly brighter in the face. I can tell when a person's feeling better before they are, because of the way their face looks. Yeah.
Do you think that it's an actual like well, you're gonna have a fancy camera soon, so do you think that it's if you took away the facial features, it would be different? If it's like actual like luminescence?
The way we all describe it is a color.
Huh.
It's definitely a different color in the face. I can't describe it, but yeah, maybe it's just the way we perceive it from all the facial changes, but they do just look a different color by the end of the week.
Yeah, interesting. Yeah, because you could often and I think that like the metaphor of light tends to come up a lot in depression.
Mhm.
Um, I was in a dark place, or I was standing on the edge of the abyss, or all these like, or like their face brightened,
Mhm.
like all these sort of light metaphors that we need to invoke to try to describe the state that people are in depression. Um, it's very interesting, even like as people are viewing them as physically darker as opposed to bright.
Yeah, it's really different. We had a few people as well FaceTime their families, and they all said, "Whoa, you look different color."
Huh.
It's very strange. Yeah, we have to do the study definitely.
Yeah. Color change
Mhm.
a proxy for mood. That's
Indication. Yeah.
phenomenal.
Mhm.
uh, well, so what are some and this is maybe what are some future directions for the research?
Oh, yes. So one very interesting thing that we found, and we need to do on a much larger sample size, and you can talk about whether you've seen this in your clinics too, is people seem to have very different time courses of response. So there seems to be three groups that we're seeing so far. So either they remit very early and they kind of hold it, which is the ideal, which is most of the sample, um, about half, and then some people aren't responding right at the end of when they finish treatment, and then a few weeks later remit and then hold it. They have this like delayed response, and then other individuals remit very quickly and then relapse quickly. um, so we really need to find out what's different about these different people in the different groups, how we can predict which group people are likely to be in, and then form treatment plans for these people. Because when we first did our open label trial, we didn't factor in any maintenance, which is, looking back on it, a bit strange, because things like ECT, medications, things like that have these maintenance programs built into them. And now looking at the relapse data for things like ECT when they don't have maintenance, it's so high. So moving forward, we really need to develop a maintenance program, but it seems like it needs to be very different for different people. For example, that case that I gave, that individual was well, 2 years afterwards, without further TMS, but other people, it can last only weeks or a month or 2 months. And we can't give them a prediction. It's so frustrating because it's everyone's first question is, okay, if it's going to work, how long for? And we can try and guess, we can give them an average, which is about 4 months, based on our small sample. But it wildly varies between people. And we just don't have any adequate predictors of that right now.
Yeah, no, it is, and that's part of the one of our collaborations with the Williams lab, the brain simulation lab, is um, taking care of the some of the maintenance for folks that went through the trial. And yeah, it is rough. And I think the good news is that unlike a lot of things in life, it's not like like with cancer treatment, you get your cancer treatment, and one of the hardest parts about cancer is like, yeah, okay, you're facing death, but like you get it removed, or you get the surgery, you get the chemotherapy, and there's some chance that it's going to come back. But that when it comes back, usually it's bad news. It's that it's spread, or it's grown, or it's harder to fight the second time.
Mm-hmm.
um, the and I don't know if you're able to, I know this might still be unpublished, but uh, what happens, or can you talk about what happens with retreatment?
Yeah, so we do have I think in the HAP paper, only 7 people were in the retreatment sample, but we can talk about those. So yeah, retreatment is very effective, and it wasn't statistically significant, but those 7 actually did better the second time than previously. So we'll have to see in larger samples if that continues later on, but at least equivalent the second time. So it doesn't seem like this is a one-time thing and then you can't do it again. It's just as effective, if not more, the next time. And again, people are different, but usually it's a slow slope back to where they were before. So we recommend people come back and get maintenance treatment when they've kind of a 50% of the way down, not all the way back down, so we can bring them back out quicker.
Yeah, that's more or less our practice as well. This is actually a viewer question. How long will it be before bipolar remission requires maintenance treatments? And I think this is probably so the Williams lab is, I understand you guys are planning to do a bipolar trial, but haven't yet done a bipolar trial, right?
We've tested some treatments out in a few bipolar patients, just pilot people so far, and it seems that bipolar patients respond much faster. I'm trying to think if any of them took more than a day. Maybe, I can't think of any, but it was very fast anyway for them. Yeah, and in terms of maintenance, we haven't trialed that yet because we haven't even run a full study on the 5-day yet with the bipolar people. But yeah, definitely something to consider. And you have to keep the balance with bipolar people too, just really making sure you don't flip people too far the other way. But we've always monitored that and it's been fine, and we haven't had anyone have any problems there so far.
The other another viewer question is, why is bipolar TMS treatment not FDA approved?
Oh, it's so frustrating. Yeah, especially, great question. Make more researchers do it. I think people are worried because there are a few case studies out there, and there's a review paper on this too, of a few people being flipped into mania from TMS. But in our experience with our pilots we've done so far, if you monitor symptoms well and you know the right questions to ask and know when any symptoms of hypomania are coming up and you know when to stop, we haven't had any problems there. But I think those case studies stop people from going forward with trials there, and therefore there's not enough data to give to the FDA to show that it's safe. But I definitely think we're on the way. I know clinics and various labs doing research right now, so hopefully we will have enough data for the FDA soon, but it's just about collecting enough data to get it approved. What's your experience with bipolar? Do you find people respond faster?
It hasn't been obviously, it hasn't been clearly faster.
And do you do type 1 and type 2 or just type 2?
We've done both.
Okay.
But again, very not massive numbers. But it does, and there have been a few more sort of unusual stories. So we've had people have one person had a just really bad, terrible day of anxiety in the midst of it. So but then we treated through that, and then the full remission came.
Yeah, there's lots of discussions about whether you need to do left and right, so that the right deals with the anxiety and the left treats the depression. Otherwise, you're going to create anxiety in people with bipolar.
Yeah, and so we with that person we had done mostly left-sided, but with a little bit of right-sided. But maybe we didn't do enough right-sided, or maybe you should be doing a lot. So there's a guy, Owen Muir in New York, and this gets to another viewer question. Where can I get accelerated TMS? There are a few clinics in the country that do it. Owen Muir in New York, and there is, oh gosh, I'm blanking on his name, in Los Angeles.
Ian Cook,
thank you. Ian Cook. And then there's a couple Brent Solveson in Sunnyvale, and me in Sunnyvale. And those are the only people that I know before the publication of the paper that were doing accelerated TMS.
Yeah, since then, there's now a clinic in Florida that claims to do Saint. So we'll see what they're actually doing. I don't know. And then, I'm blanking on his name. Someone in San Diego. I will remember soon.
Okay.
Someone in San Diego doing it, but maybe there's more. Yeah.
Yeah. So it's probably, now that this paper's been published, it's anybody who's got the right equipment can do it, or at least can do a close approximation of it.
Mm-hmm.
Yeah, I wanted to get back to something we talked about earlier and push the limits of our technology here, and show you speech arrest.
Oh, great.
So I'm going to show you.
Who's delivering it to you?
Let's see. This is a demo I did when I was in medical school.
Oh, great.
Oh, I'm not sure this is going to be, the audio is working here. Can you hear that?
So first
Yeah.
we're going to start off with the motor cortex. So my right motor cortex is going to be stimulated. We're going to get various hand movements. And here we've localized just to my thumb. And as we move up the cortex, getting other fingers, and even the whole hand.
It's quite a high level of stimulation they're giving you.
Yeah, we don't mess around. we had to make it look good for the video.
People who come in for trials, just to let you know, it's much calmer.
This is the do not attempt at home. This is for demonstration purposes only.
Yeah.
Now we're going to go to the left inferior frontal gyrus. And before we stimulate, I'm going to say that Peter Piper picked a peck of pickled peppers. Peck of pickled peppers Peter Piper picked. If Peter Piper picked a peck of pickled peppers, where's the peck of pickled peppers Peter Piper picked? And now with stimulation. Peter Piper picked a peck of pickled peppers. A peck of pickled peppers Peter Piper picked. Peter Piper picked a peck of pickled peppers. Where's the peck of pickled peppers Peter Piper picked?
There you have it.
Proof. That's great.
Speech arrest.
Yeah, I love you're donating your brain for the cause.
Yeah, no, it's all fun and games until you have a permanent speech arrest. But
We
no,
always do
that
that
doesn't happen.
demo.
That's not a thing.
Yeah, we always do that demo for Stanford undergraduate students when they come in their first year and they come into the lab, they all squeeze in, and then Dr. Williams does that to their instructor, their teacher, and they all look really concerned. Make them count down from 100 and they just get stuck on one number over and over again. Very funny.
Yeah, no, it's fascinating. It's fascinating. I mean, and it's, you know, the cool thing, I mean, this is, again, we're getting back to the conversation about TMS as a pro, but it's it's the we're able to demonstrate a lot of these classical neuroscience effects. So, you know, back in the day, you'd have to have, like, in the midst of neurosurgery, you know, have somebody stimulate that part of your brain, and then you cause speech arrest. So that was, so the classical Broca's area. And so when you stimulate that part of the brain, it interrupts its processing and they can't talk temporarily. And then my brain goes back to normal after the magnet stops firing.
Yeah, only temporarily.
Temporarily. But I mean, you know, presumably if you kept doing that, there might be longer term effects. And that's kind of with TMS, the like long-term plasticity is the idea that, like, as you continue to teach the brain, this is how we want you to be, it stays that way. And so if you just push it a little bit, it doesn't change permanently. You push it a lot, it hopefully stays in shape, which in this case is undepressed.
You can also find, when you use TMS as Pro, very interesting things out about yourself, like Dr. Williams, who only gets speech arrest when you stimulate on the right side and not the left.
Really?
Which is very unusual because he's also right-handed. So I can't remember what percentage it is, but a very small percentage of the population who have the speech center on the other side.
Huh.
Mm-hmm.
Yeah. No.
Only knew from a TMS demo.
It's not working.
Mm-hmm.
Um,
So you can do mapping on yourself.
we talked about bipolar, we talked about depression. What are some other, we talked about anxiety as being something else that might be treatable. What are some other things that got better along with the depression that you noticed?
Oh, that's a good question. I can tell you one thing that didn't, and that we are doing a different treatment for while I think about other things, is OCD. So people who had comorbid OCD or OCD type traits tended to not do as well in our sample so far. That's one thing we're finding. They may need a different treatment target. And the FDA approved TMS treatment for OCD right now is the dorsal medial prefrontal cortex, more central, getting to this area called the anterior cingulate cortex. But we're actually trialing a different area called the right orbitofrontal cortex, and its connectivity with the striatum, which seems to be effective so far in our small sample. So we'll let you know when we get more data from that. But it just seems that individuals, even if depression they believe is their primary diagnosis and they have comorbid OCD, they just tend to not do as well. So we definitely need to do more research there about how that maybe looks differently in the brain. Maybe we need to try a different target area or a different pulse sequence. I mean, there's many other things we can change as well in the TMS protocol, things like how often we're delivering the pulses, what frequency we're using, things like that. And maybe that needs to be different in these individuals. So there's lots of questions that we have on that. What other things got better? Definitely the mindfulness thing was a huge thing that we really didn't anticipate.
One thing that with some patients that we're not really necessarily consciously targeting, but we had a couple patients with fibromyalgia or like chronic pain conditions that just had substantial benefit over the course of both conventional as well as SAINT treatments. Anybody in your sample with pain?
Yes, we did. And we did actually end up tracking that too. We had a couple of people with fibromyalgia and their pain got better. So one of our postdocs in the lab, James Bishop, is going to actually look into running a trial for fibromyalgia because their pain scores did decrease so much during the treatment. Maybe that the left DLPFC is a good target for pain treatment as well. And two individuals did have a very strange response in terms of PTSD as well. I don't know if you have had this, where they had during the stimulation, I can think of two people this happened to. They relived a traumatic experience during the stimulation, and then after the stimulation could process that much better, and they were suddenly much more accepting of that trauma that happened. They had these very vivid experiences of reliving the trauma, almost like we were doing this psychotherapy during this, even though we weren't, there was no interaction with the individual whatsoever. But two of them now, Jonathan Downer in Canada, when I was there, he had a participant who had this during the stimulation. They relived this very traumatic event during the stimulation. Suddenly, straight afterwards, they were much better able to deal with it and relive that memory in their mind and deal with it in a much healthier way. It's really interesting. Definitely did not expect that.
That's fascinating. Also, yeah, again, like we're trying to treat depression. It's like all the other things are also getting better with pushing people in the direction of what is, often thought of as, top down or executive control or, dare I say this extrapolation, but rational thought. The kinds of that maybe depression is a condition where the rational thought part of your brain is just not as effective or connected, and so the talking to yourself, talking back to these thoughts doesn't work or isn't connected or isn't as effective. So
we've had lots of people who they say they were reporting before they came in that CBT just did not work for them. They just couldn't do it, and their therapist is getting very frustrated. And then afterwards, it all made sense and it clicked.
Yeah.
Someone described it very well to me. They said it was like having a personal trainer, but your leg's broken. You have the best personal trainer in the world. There's no way you're running a marathon.
Right.
As soon as you've got that leg fixed, great, let's train. But there's no point training if that secretary's not there and they're not able to do that training. So yeah, lots of people said that afterwards CBT was very helpful for them, which it wasn't before. And we actually did neurocognitive testing before and after, just to check there was no negative cognitive side effects, like things like ECT. And we actually found that not only was there no negative, there actually were some improvements in executive functioning afterwards.
That's spectacular. Well, this has been a delight talking with you, and I'm just so excited about the work that you're continuing to do. And thank you for coming on the show, and keep up the great work.
Thank you. You too. Thank you for having me. That hour went very quickly. I could talk about this stuff forever.
Yeah, well, shows you're passionate about it. So thank you for coming on.